Hi, I'm Ravenna. Thank you for joining us for our webinar today. The purpose of this webinar is to give you scientific background about CPM, conditioned pain modulation, and to present you our Medoc 2 thermode CPM system. CPM has become the hottest buzzword in pain research. It is the center of many conferences regarding pain, and in fact, it is mentioned in every pain conference in the past year. So any pain researcher who is seeking, investigating new areas would be interested in CPM. We are aware that some of you have more knowledge and some of you have less, so we will start from the beginning and give you a full overview about CPM. We are hosting today Dr. Yelena Granovsky from Rambam Medical Center. You will be able to ask questions during the webinar by placing them in the question section on your control panel, and we'll do our very best to answer them all. So, Dr. Granovsky, hi.
Hello to everybody.
Can you please start by explaining what is CPM?
Yes, sure. CPM is conditioned pain modulation test. What it means? It is a test developed by us and by other researchers that makes possible to assess our pain modulation internal analgesic system in humans. This test bases on neurophysiological phenomena that is known as DNIC, diffuse noxious inhibitory control. In other words, is pain inhibits pain phenomena. So now I will give you example what exactly this test means, how it performs it, and then I will explain you what is the importance of measuring conditioned pain modulation, what is importance for patients in clinical settings, for researchers, for clinicians, and you are welcome to ask any question. Just as Ravenna mentioned, you can type it, and I will be glad to reply to answer to your question.
Another way to ask questions is to raise your hand. It is also on your control panel, and we will try and answer it right away.
Okay, can you please?
Yeah, can we continue? Okay.
So again, CPM, it is a methodology that makes possible to assess our internal capabilities to modulate our pain. An example appears on a slide. For example, I give a certain painful stimulus. Let's say that I choose to test CPM with 2 noxious heat pain stimuli. So first, I give a stimulus. It can be either absolute noxious temperature. It can be predetermined psychophysically, individual-based temperature. For example, we're working with a temperature that evokes 60, pain 60 on a 0-100 scale. Right now, it doesn't important. There's different methodologies to evoke CPM.
As long as it's painful, right?
As long as it's painful, yes. That's the meaning of the test. That is the definition: diffuse noxious inhibitory control. This is physiological phenomena, as I mentioned, that underlines this test. So let's say I give a certain pain, and again it evokes a rating of 60. And let's call this stimulus A. After a short break, I give another stimulus, different stimulus on another body side. For example, if initial stimulus A were given on the left forearm, after a short break, I ask the subject to immerse his hand in another hand, a contralateral hand, in hot water, or I place another thermode on the contralateral shoulder. And during the exposure to the second pain, let's call it stimulus B, I repeat again same stimulus A as I gave, let's say, 10 minutes ago. But when it's given simultaneously with the stimulus B, it will induce a lower pain than when it was given alone. For example, if before I rated it as a 60, during a repetition of the same stimulus given simultaneously with another pain, I would rate it 30. So this reduction, let's say reduction in 30 units, reflect my ability to reduce pain, my efficiency of the CPM response, or in another word, the capability to reduce my internal pain. Usually healthy subjects, non-pain patients have this mechanism efficient. We know about high variability in extent of these responses, even in health population. But what we know for sure that this mechanism is deficient in pain patients.
Yes, what you're saying is that actually all of us have a certain pain modulation mechanism in our bodies, but normal people, healthy people, it is an efficient mechanism, and pain patients have a deficient mechanism.
Deficient or less efficient?
Or less efficient.
Yes.
Okay. Okay, so we'll move on to why is CPM important. Can you tell us?
So as I mentioned before, this test reflects our ability to inhibit pain. Why it is important? We run in our hospital several studies, and we have several replications of our findings from another researchers that the result of this study showed that, for example, ability to induce CPM to evoke efficient analgesia in laboratory setting, it relates or predicts, for example, development of future pain. We're talking definitely about the development of post-operative chronic pain. This was demonstrated again by our group in patients that underwent thoracotomy, major chest surgery. So we tested a large group of patients that were pain-free at the time before the surgery. Mainly had lung cancer, so any kind of tumors, but they had no pain. And we assessed different tests, including the CPM. And then we followed up these patients after the surgery on their acute pain, and followed up to 1 year, I think, studying and recording the incidence and intensity of chronic pain. And we found very clear, and this paper was published in 2008, that patients with efficient ability to evoke CPM, those who could demonstrate the ability to inhibit their own pain, endogenous inhibit experimental pain, those patients have less chances to develop chronic post-operative pain, and if they do have chronic pain, the intensity is lower than in the patients that it's like a healthy subject. They are more pain-free, but they, from some reason, had less abilities, less capabilities to inhibit in experimental pain. We talk in experimental setting. Again, it's very important that it means that using experimental pain that's easy to run, to apply, to measure, you can predict or somehow to make some impression what patients going suffer more. It means that same patients probably need to have in advance more aggressive,
more medicine, more
aggressive treatment, or certain group of pain relieving medications. So many clinical outcomes can be made out of this study. As I mentioned, that the study was not these patients, but similar results were found by major abdominal surgery patients. Again, the pre-treatment CPM predicted the incidence of post-operative pain. And another point, again, we can talk about it later also. So CPM is working based on certain mechanism, endogenous mechanism, neurophysiological mechanism via certain neurotransmitters, certain constants of our body that involved in this inhibitory response. So if we know that, for example, CPM is deficient, we can think about what neurotransmitters are deficient and what we would like to restore. So you can make actually individual treatment
yes,
mechanism-based treatment approach. So I think I covered the importance of CPM. Let's go to another slide.
Okay. We will talk now about some common CPM protocols that are used around the world now.
There's variability.
Yeah, there's a large variability, so you will explain some of them, the most common, and we will see later that to standardize one protocol would be very difficult.
Okay, so since we're talking about the pain inhibits pain phenomena, so we need two noxious stimuli.
And they have to be painful.
They have to be painful, but we know from other studies that well-perceived, even if it's not noxious stimulus, usually if it is applied on large body area, it also can evoke some kind of analgesic response. But again, by definition, when you're talking about CPM, that is the NIC-based response, we're talking about two noxious stimuli. And right now, not we, not anybody else can tell what combination between test, as it was stimulus A, let's say, and the B, that it was another hand immersion or another thermode placed.
We'll go through some protocols now.
On the shoulder, what is more efficient, or what is a more classical or more applicable or more clinically validated. We are not there yet.
Yeah.
But I can tell you what is more, what protocol are most popular or
so
has more clinical application.
So let's start with the noxious contact.
Yeah. So the first is noxious contact heat as a test stimulus and hot water bath immersion of up to the wrist. Of the other hand, as a conditioning stimulus, it is a popular protocol. This protocol, that is what we're using in our lab, and we did several studies and published results. So if we're talking about not only popular, but protocol that has some clinical meaning, some clinical importance, this is a protocol that was proved to be related to some clinical data. It's not enough to say that I give two pains and they see that one pain inhibits another. It's not
clinically relevant.
Yeah, so you should apply it on patient, and if it shows some relationship, some effect to clinical pain or to drug effect, so you can say that that's what you're looking for.
Okay.
And for this protocol, as you see in this slide, again, we could predict successfully the acquisition of chronic pain after chest surgery. Another group published some relationship between CPM efficiency and gynecological pain after gynecological surgery. And we also could predict what patient, neuropathic pain patient, could have more benefit, pain relieving benefit from Cymbalta. And Cymbalta, this is a medication, as I previously mentioned, is a medication that restores the deficient, the same neurotransmitters that probably deficient in CPM. This drug restores noradrenaline and serotonin, so it's a very important study that we published in 2012 that's saying again that the patient that have efficient CPM, not everybody has deficient CPM.
Yeah. The patient who has would be beneficial from
the patient that have efficient
drug.
CPM, they would not get benefit from Cymbalta, but those who are deficient
would benefit from
that they have less, there's something that the drug can restore.
Mm-hmm. Okay,
so
let's go to the next protocol.
Yeah, okay, so next protocol is another frequent protocol that relates to using of pressure pain. It's usually algometer pain.
Or something that uses a cough, like blood pressure cough.
But usually it can be blood pressure cough, of course, as a test stimulus, and the hand immersion in cold water, for example. So not everybody immersing his hand in hot water. Some groups likes or prefer to use a cold, noxious water. And this protocol was used and shown clinical relevance in predicting chronic pain after abdominal surgery, for example.
Yeah. Okay. We'll go to another protocol.
And another protocol is another group from Holland, I think. They use a brief electrical stimuli as a test stimulus. That again, they give it alone, a standalone, and during immersion of another hand in cold water, it is their favorite paradigm. And they showed that this paradigm, this CPM based on this protocol, was efficient to predict analgesic efficacy of another pain-relieving drug, pregabalin. So the aforementioned protocol, that is actually what we have for now to relate it to clinics. But it's a lot of protocols. You can place thermode or another or any pain on different body sides. It's also the question if you have the preferable body area to work CPM. Maybe if I use same protocol on different body areas, I would get even better results if I, let's say, put it on a leg and not on the forearm. But this is what we have so far. The most popular sites is still hands and arm.
Okay.
And hot and cold water.
Okay. Actually, in the last FWIC conference, a group of about 30 pain researchers from around the world gathered together on a session trying to decide which combination of what noxious stimulus as test and which condition stimulus would be the best for getting the best results, but there's no solid conclusions yet. We're not sure that there will be, because as you saw, there are there's a large variety of protocols. We'll make a little stop now and see if you have some questions. You are able to either raise your hand and we can hear you, or you can type a question in the questions section on your control panel, because we haven't seen any questions yet, except one. No. Okay, so if there are any questions, we will go on, okay? Now we will present the two thermode CPM system, and we'll talk a little bit about their advantages. So you would like to say something about it?
Yes.
Okay.
So as I mentioned, a popular paradigm is using conditioning pain, stimulus B, as a hand immersion in the water, but it has several disadvantages. First, if you want to have this test in clinical setting, you cannot perform it because of patient that is in lying position, he cannot immerse his hand. It's very uncomfortable, it's complicated, and so on. So having, giving two pains or two stimuli for example, as a Medoc's machine to thermodes that can induce painful stimuli can solve this problem. So we can develop a paradigm that can be applicable even for patients at the bedside.
Yeah. Another thing is disinfection.
Yeah, sure. When you use a bath, you should clean up it after each patient, and it's not always. It's time consuming. It's not always possible, especially if you have several patients in line. Some patients just don't like it because of it's less aesthetic than if you would have a thermode placed on your hand, arm, or shoulder. And another advantage is that when we're using BAD, it's also computerized, but we don't always know, especially if you're talking about cold water, what exact temperature that we're actually applying. Here, we're talking about a computerized system that you can you decide the temperature to give, how long it stays, you choose the parameters. It's easier to choose and to change the parameters for baths. It's more complicated. So it's more easier and more convenient for the for somebody that performs the test. Yeah. So it certainly has advantages.
We'll try showing you now a test taken with the 2 thermode. We're not live taking it. I recorded it earlier, but I think it shows pretty well what it can do. Okay. We'll show you a pain rating test in a few seconds. Okay. We'll show you this pain rating test. A nauseous stimulus is given, and the patient has to rate it. Okay. So at first they rate it as 60 from 1 to 100. And for this, after the stimulus was given, it was first stimulus repeat. Show you the report generated. Okay. So this is the report that was generated. Do you want to say something about this? This is the stimulus before the condition. Stimulus was applied, and this is the same stimulus after parallel to the condition stimulus. As you can see, it was rated with approximately 20 units less. So this is what CPM is all about.
Yeah, I think it's a little bit different paradigm that, let's say, we work in our lab, but it's definitely one of the paradigms that could be used instead of one 30 seconds or long tonic stimulus to give several repetitions. It's absolutely acceptable. And to repeat the same intensity, that is what important. You repeat same intensity and you get lower pain when it's given in parallel with a painful stimulus. So that's what exactly your example.
We can show you another test that would be limits, CPM limits. And as we saw before, we give a stimulus and the patient is asked to stop it when he feels this is when he feels pain. Okay, we'll forward it a bit. And then you can see when the vision stimulus is being given, the threshold is higher. Can you explain that?
Yeah, sure. You brought an example of sensory threshold.
Yes.
And in the literature, yes, it should be actually the pain threshold.
Yes, but this we did in temperature, as you said, just sensation. Even in sensation, it works.
It may affect also, of course, Yes, so it's another paradigm widely used also for heat pain threshold and for pressure pain threshold, that instead of giving a tonic pain or several repetitions of pain, as we saw in the previous example, you just measure the threshold and repeat the measurement during or simultaneously the application of the conditioning pain. And usually we see that the threshold increases. It means that you exert the analgesic response and you need more intensity to get to the pain threshold levels. Yeah, so definitely it can be a paradigm.
Okay. We'll go back to our control panel and see if some of you have questions. How will a CPM result influence an operation procedure? Change the anesthetic, perform or not the operation? What should the surgeon what would the surgeon plan if a patient is found to be CPM deficient?
It is a very good question. Right now we know about the incidence of post-operative pain. It's not exactly a surgeon problem, it is an anesthesiologist's problem. And one of the ways to diminish, to avoid post-operative pain is to use the preemptive treatment, analgesic treatment before the surgery. Right now we start running in our hospital a study that is aimed to test whether a CPM response is related to the effectiveness of treatment. So you usually, or many of anesthesiologists, they advise to their patients to take certain analgesics for several days, as it may reduce their post-operative pain. But again, we want to be sure that we can advise the correct treatment to correct the patients. So if it's mechanism-based approach, and if it has deficient CPM, so probably you could benefit more from Cymbalta than from other drug. And if you would get exactly Cymbalta at the pre-surgery state, he would a patient that would less suffer from the post-operative pain. So it is to your question, yes, there is a benefit for surgeons and for anesthesiologists that using the CPM assessment, you can learn about the effectiveness and individual-based choice of the preemptive treatment.
Okay. We have another question. From which percentage change in VAS can we say that CPM is efficient?
We cannot tell right now. It's a good question.
Tough question.
Yeah, we know to answer it, we need a lot of patience to say how much or what change is not efficient. We know there is a variability in healthy subjects, but about 1/3, 30% of healthy subjects have it non-efficient below 0. We, for us, have a cutoff of 0. If it's above 0, it's efficient. If it's below 0, it's deficient. And for patients, we know that this cutoff is different. Like patients, and most of them have deficient CPM. But whether it exactly should be the 0 difference or it can be other minimal difference, we cannot tell right now. Again, we have a lot of studies done on healthy subjects. We need to perform more studies on pain patients, and according to it, to define what change is efficient or what change is deficient. Another approach is to choose the median, and to say that if somebody is above median is efficient, below median is deficient. Again, if you compare healthy and pain patients, you see that the median, of course, is also different because of patients as a general, the population have deficient CPM response. But to tell exactly what percentage is it's showing somebody as deficient or efficient. We cannot say now.
Okay, another question regards the programs we saw before. Does the patient stop the intensity of the pain in the previous program? Well, in limits, of course, they stop it, and in the previous one, when they rate the pain, no, they don't. They just rate it once the pain is, during the pain or once the stimulus is over.
The stimuli very, very short, but
Yeah.
if your question is if there is possibility to patient to stop the pain, if it hurts too much,
yeah, there
how
is,
you
of
press
course.
a
Yeah.
stop button or
Yeah,
any response unit.
Yeah,
I'm sure.
Okay. Just another question. Just in regards to the previous question, which one? So there is a link between post-operative pain and CPM deficiency.
Yes, sure. It's a link that the pre-operative CPM efficiency predicts or is related to the intensity of post-operative chronic pain. So this is a relationship that is known, actually predictive relationship.
Okay. If there are more questions, we would be happy to answer them now. For those of you who weren't able to participate, we recorded it, so we will send it later so you can listen to it again. And of course, if you have additional questions later on, you will be able to send us. So there you see more questions. Do you have anything to summarize this?
Let's see what we have in our...
No, we don't. These are all the questions.
No, not the questions.
What?
Our slideshow. Do we have more topics to cover?
No. If you have...
no.
I think we covered most of the frequently asked questions.
Okay, just maybe I could mention or name the pathologies that in their field we know that CPM is deficient. So overall, it's a pain patients, but talking specifically, many studies that showed that CPM is deficient in migraine, in fibromyalgia, it is widespread muscle pain, in osteoarthritis, in irritable bowel syndrome, in pancreatitis, in whiplash, in neuropathic pain.
It is very common in many pain states.
It's very common in many pain states. It's what is important when you test the CPM, you don't place thermode and you don't apply pain stimulus on a painful side.
Yeah, of course.
You apply the mode from the painful body side, and it exactly reflects your central mechanisms of pain modulation, your central ability or your ability of your central nervous system that involves the spinal cord, the brain, cortex, and subcortical brain structure to modulate pain. Again, it's central phenomena. It's very known and a very well studied phenomena of deficient pain inhibitor abilities in pain patients. And now we just know to find to make it fine-tuning, to find the best paradigm. Maybe finally we will end up that certain combination of test and conditioning stimulus fits to certain pathology. And it could be great, and it has future clinical applications.
Yeah. We have now another question.
Okay.
So this means that the thermode should be placed close to the operation field?
No, it doesn't matter. No. We did it completely remote. For example, in a thoracotomy study, we put a thermode on the forearm, and the other wrist, a hand up to the wrist, was immersed in hot water, and the ablation was performed on the chest area. So it's not the same dermatome, and it's a remote body area. Some people just using legs, applying a test on a leg. So it also can reflect what's going on in, or to predict, to be related to pain from surgery on another body area. As I mentioned before, the phenomenon is central. And again, it has certain methodological consideration, but generally the placement of the thermode or any other pain, it should be on the non-painful area, so it should not be done on the
operation side or very close to
it.
Yeah, we have another question. Would it be possible to have a simple diagram of the physiological of the
right now I don't have it here on the slide, but
we can send it later.
We can send it later.
No
you
problem.
can get into the. I like personally the. Actually, you need a physiological anatomical picture of the pain descending inhibition.
Yeah.
I like a lot the schemes from publications from Daniel Levar. He has excellent review from.
Yeah, I suggest that you send that question to me via email, and we will do our very best to send you exactly what you need.
There is several good reviews. They're very scientific, so they're not easy to read, but they're excellent reviews, and including the schemes. So just tell if you need, and we will send it.
Okay, so just it was a question from Switzerland, so please send it to my email, and we will be happy to provide anything you need. Anything else? Any questions for anyone else? I don't think so. Okay, so if you don't have any other questions, we will thank Dr. Granovsky for joining us today. I hope it was beneficial, helpful. Of course, if you have any other questions or information you want to know, please contact us, and we will be happy to host you in our next webinar. Thank you.
Okay, thank you.